Dr. Patino here at the Cosmetic Surgical Center for Cerrito. So we're gonna do bloodless tummy tuck, okay? And this is what we basically do all the time. And as you can tell, you know, it's a pretty slow technique. I just go through the epidermis for those doctors watching. And I was teaching one of the doctors here in California, and he said, "That's a scratch, that's not a real incision." It's true, it's just a scratch, right? But that makes it so that you don't bleed, right? Because from the get-go, if you go all the way down to fascia with this incision, well, there is going to be a lot of bleeding. You can't control that because you cannot really see the blood vessels, right? But if you go slowly like this, then you can be very meticulous, and I am ridiculous. Okay, so we have now subcutaneous tissue, and this of course is scarpa's fascia. So I'm dividing the scarpa's fascia, which, as you know, separates the superficial subcutaneous adipose tissue from the deep tissue. So scarpa's fascia separates, of course, this is scarpa's right there, superficial fat from deep fat. And oftentimes the color of the deep fat is a little different, right? But in this particular case, I don't think you can tell too much the difference in colors. And we go slowly, looking for any blood vessels here, right? And then, of course, we're gonna encounter the deeper tumescent anesthesia that we have here is incredible, right? There's a little blood vessel there, but we electrocoagulate them as we go. Thank you. We are going to follow the linea alba. It's a hyperpigmented area, obviously, that happens after pregnancy. And just do an electrocautery here for this area, which is the specimen, of course. And we're going to go through it in a completely bloodless manner. I don't know if you can see from that angle. Maybe I've lifted on this side. You can lower it there, and I can lift it here so that they can see a bloodless feel, right? Very good. And let's show them inside also, so that they can see. Thank you. And they come around the same line, so we're expecting another perforator around there up above. And depending on the size of the patient, the perforators may be more spread apart, but you can usually spot them. And of course, if you go very fast, you're going to miss them, and there's going to be blood all over the place, right? It'll be all red. But we want to do this in a very controlled, slow manner so that there is no bleeding. And you may wonder, well, what's the big deal if there is bleeding, right? When you go and do a blood transfusion, you know, you lose 1 or 2 cups of blood, and then you go right to lunch, right? No problem. It is true, and I'm perhaps exaggerated when it comes to controlling the need for blood transfusions, the risk of infection with hematoma, but I believe also, and I learned this from Dr. I'm blanking on his name, I'm sorry. Dr. Do you remember? Dr. Chad Deal, yeah, sorry, good job, you remembered. So I was in a conference with the World Association of Gluteal Surgeons, and Dr. Chad Deal mentioned that the blood is irritating to the tissues, right? So the blood, when it's extravasated, when it's out of the blood vessels, it irritates the tissues and blood because he thinks there's, less risk of complications with that. Of course, hemosider and staining and bruising, and there's a lot more than we probably don't know about what it's not just the anemia, the post-operative weakness and fatigue, and maybe even shortness of breath from anemia, but there is other things. I think seromas, definitely, we just don't see seromas. I can probably count in one hand the amount of seromas that I had in 18 years. So it's incredible. Thank you. Extended tummy tuck. So look at my hand. I go all the way up to the end of the chest bone. That's the xiphoid process and the rib cage on both sides. You can see the white fascia is white, the yellow fat is yellow, and this is your umbilicus here in the middle. And we're gonna go ahead and sit her up and exercise the specimen. So once we take the specimen down, all these things are going to go out. Look how tight and nice it's going to look, and the same on this other side. See? Thank you. Go ahead and mark the specimen. The patient is sitting a bit, and we're going to go all the way back here. Thank you. To go and make another line, because I measured with this towel clamp how far I could go, and it wouldn't reach up there. So this clamp I use to basically pull up and see if I can feel the clamp there. That means I can go there. But obviously I couldn't, so I did the same on the other side. But this is basically just a scratch, like one of the doctors, Dr. Jury Connect, told me, hey, that's just a scratch. He's a great guy, and he's doing beautiful abdominoplasties, and he does the lipo-abdominoplasty technique, and we have the pleasure of having him here. And
move the specimen on the left side right here. Got some stretch marks out, and on this side there's no bleeding, just the fat you see. Very nice. Thank you.
To make the incision for the umbilicus to come out of, and then I'm gonna basically remove the top part with medicine bound scissors, right? But right now I'm gonna go ahead and put my finger through it, and Emily, you're gonna come on this side, right, to irrigate, because I find out that irrigating is important. Otherwise, the skin can get some serious heat, and the skin can be burned. So yeah, you can go in there, and if you put your finger here, this would be very hot from the calories. But that's basically it, and that's my finger right there. Thank you. Plication, right? And the patient is fully paralyzed for these. I've done it without paralysis under tumescent anesthesia, but I think it's important. You probably get a better plication. I do multiple figure of 8 sutures because just in case that one of these sutures breaks, then you have a supporting suture on either side, instead of doing a long suture, right? Because if that one continuous suture breaks down, man, the whole repair breaks, right? Along with it. And we never had that happen, but just very careful. And we like to use all probing for this procedure. And all probing muscle plication down this way. And pretty much Bloodless manner, right? So we do these routinely in our cases, right? What we're doing is we're trimming the belly button. Remember how the belly button, we burned the edge of it because of the cautery? Because the cautery is a burning instrument, right? It burns, right? And it burns and it stops the bleeding as it does so, right? So now what we're gonna do is we're gonna refresh this edge of the umbilicus, right? And so I just make it really, I trim it real good actually, and I'm gonna go around it and so trim this belly button nicely like this, see? And now it's all done. And we will then, suture it to the fascia so that we can create some depth. I'm going like that so that you guys can see and now we're going to use some dual Vicryl to secure it. We're done. I'm going to turn the patient to the side to address the love handles as well, so make sure that there is no dog ears. But look how beautiful she is. She's nice and flat, and the belly button is sinking in nicely. Thank you. Now, so look at her. She's on her side. The buttocks are over here. A beautiful suture line, gorgeous waist, no excess skin, no excess fat, no dog ears. And thanks to God, today is Friday. Woo! Thank you, everybody. Love ya.